Welcome back to Plenary Session Podcast. This is episode 7 of the Malignant Book Club. I'm joined by guest host, Dr. Timothy Olivier. Timothy?
Hi, Vinay.
It's good to see you.
Good to see you.
How are you, Timothy?
I'm fine.
Is this the hottest day you've experienced here in the Bay Area to date?
I think so. They are forecasting, I think, even hotter tomorrow. But
wonderful.
I'm not sure about that.
Let listener know that it's awfully hot here, and this is a land of limited air conditioning, so we're going to be sweltering it out. So if you're watching the video and you wonder why they're sweating like it's an interrogation, rest assured it's the temperature outside. All right, so we're getting started. We're back here, episode 7, the Malignant Book Club, chapter, 10 or 11?
So we finished yesterday with chapter 10.
Okay, and now
so
we're
have
starting
11 and 12.
So we're rounding out
11
the third part of the book. We're rounding out the third part of the book. So what are we talking about today?
So today it's the chapter of important trials. I think by this you want to just illustrate the points that you are making before, that you were making before. And it's really interesting because sometimes it can be counterintuitive, the findings you are describing. So maybe let's start with this very well-known trial about the marker Ca125. And this was a very important trial in, I think, in 2009.
Oh, that's a good one. Yeah, so I think the purpose of this chapter is really to tell readers about some of the seminal studies in oncology. And, I'm often, I guess I shouldn't be surprised anymore, but, it is kind of surprising that sometimes people graduate Hem/Onc fellowship and they don't know all these trials. That to me is a bit surprising because some of these are sort of fundamental classic studies in oncology. And I opened with a big one, which is the Ca125 study, which I believe was an ASCO plenary session in the 2000 and aughts. And what was this study? I mean, we know what is Ca125. It's a crude cancer marker for ovarian cancer. And it's been tested in combination with transvaginal ultrasound as part of a screening test in the PLCO randomized control trial. It failed there. It also plays an important role in following somebody who has documented ovarian cancer. And as the disease responds, the Ca125 will fall. As the disease recurs, the Ca125 will return. And that was the basis of a randomized control trial. So a woman who's undergone, primary treatment of advanced or metastatic ovarian cancer, typically surgical debulking, she's being followed. There are 2 ways you can follow such a woman. You can follow them. I guess there's more than 2 ways, but there's at least 2 ways. 2 ways in this study. One, you follow them clinically and radiographically, waiting for radiographic signs of tumor or clinical decompensation before you say they've progressed and institute second-line therapy. Or you do those things and the Ca125 blood marker. And the idea was the Ca125 blood marker might be a little bit more sensitive. It might detect the cancer when it recurs a little bit sooner. That allows the doctor to pounce with the second-line chemotherapy a little bit faster. And you know what is going to happen? Women are going to live longer because of the routine surveillance of these ovarian cancer patients with the Ca125. And that was the basis of the randomized control trial.
So what was the result of the trial?
And the result was...
So first, I think it's really the proof of principle that you can run trial on strategy, on different strategy. I mean, this is really an example of a trial, what trial we would like, I mean.
Yeah, that's a great point. It's not a trial of a drug. It's not a trial of a device. It's a trial of a strategy, the routine application of a blood test. When people say, "Oh, well, we can't study, with dynamic, that we can't study the addition of dynamic to routine clinical care or not." Yes, you can. You can study the addition of a blood test, a genomic test to routine clinical care. When we talk about foundation medicine in chapter 8 on precision oncology, you can randomize people to getting the foundation results or not and seeing if they have any lick of difference in survival. And this is a similar thing. It's a proof of concept that you can randomize women to different surveillance strategies and measure the hard outcome of how long they live. What did the trial find? The trial found that if you use the Ca125, you will find the cancer come back sooner. The PFS curve is precipitous. You find it come back quick. You institute chemotherapy way sooner. Way sooner you institute chemotherapy. And unfortunately, there's not a lick of difference in overall survival. They live just as long. And all you did by using this marker was take whatever days someone had left on this planet and made sure that more of them were receiving chemotherapy. Just added toxicity without gain.
Yeah. And I think the point of added toxicity was also documented in this trial. And an interesting point here, and you talk about this in the book, what happened between before the trial and after the trial in the current, in real life practice about the use of Ca125.
Oh boy!
And I think the answer. It didn't change nothing.
That's what I was about to say.
Yeah.
I've forgotten, but I think there is documented
And
data from the real world showing that people were doing it before, and this trial did not get them to stop. And the reason I would know the answer is that that's the theme of ending medical reversal, which is that when there's a medical reversal, it takes people about 10 years. There's sort of 10 years of inertia before they start to change. And we document that in the first book. And I think this is a good example of that in oncology. Yeah. And this time I have the book. Astute viewers of the show will know it rests behind me on the bookshelf under I think, what is that? Under a plant. But now I've picked it up and I leafed through it. So
Don't look.
Oh, don't look. Okay, okay.
No, you can look.
No,
No,
supposedly. Well, the medical writer wrote it, actually. The medical writer wrote the whole book, yeah.
Of course.
Really.
Like,
I just said, okay to submit.
Okay.
Yeah, okay to submit.
Yeah.
But it was really a really unique medical writer to know all this stuff in here. I don't know. The medical writer did it. All right, so yeah, the Ca125 story is interesting. It's also this like classic parable that more information isn't always better.
Yeah.
We always think more information is better, but it's not always better.
Another thing we have to say in our practice, what we can see that every scan, every laboratory is the occasion for the patient to be worried about the result.
Right, scanxiety.
And this is normal, and I'm not criticizing doctors for doing scans and things, but we have to consider this in our practice. This is always an occasion for a lot of stress, a lot of anxiety. How will be my result? Will my Ca125 will be higher? How much higher? And this is also, I think, a very important point.
And then let me see. I don't know if I said this in the book. You tell me if I said it. This is also an important reminder that the surveillance for every single other cancer is literally just invented by somebody. Like, we don't have randomized controlled trials that say with what frequency someone should get chest radiography post-testicle cancer treatment. We don't have randomized controlled trials in any of the major cancers about how often you should scan them, how often you should draw, CEA, how often you should see them in clinic, how often you should perform physical exam. We've never tested the different surveillance strategies, but that's ripe for testing. In large cell lymphoma, I think we do have some data, like why we don't do routine scans if they're PET negative end of treatment, and that's largely leveraging population data from Denmark and from Sweden, and I find that compelling as a good reason not to do it. But if you really really think about it, we should be running randomized control trials in every single tumor type, randomizing people who've had curative lung surgery or curative colon surgery, or curative breast surgery to different interval scans, plus or minus physical exam and a factorial design, to maybe even once yearly scans. And if that turns out to be, equivalent or even better, less treatment, less time on treatment, same OS, then maybe we even go to every 2 years, or we don't do it at all. We just don't know. Is that in the book? No.
No. Maybe in other parts of the book, not here, but I think it's a very important point. It's related to what we were talking in the last episode about. I think you can be more flexible when you don't have very strong data supporting something. For instance, if somebody wants to take some holidays and maybe CT scan will be delayed after 3 years of follow-up, maybe if you don't have strong randomized data, you can just relax a bit and,
That's well put,
I think this kind of thing. I think most oncologists are like that, of course, but it's an important point.
That's to your point, which is that, when you understand the limitations of the evidence, it also helps you knowing when to relax. You don't have to take everything so seriously. The things that really do matter, you take those seriously. But these things that don't matter, that don't have evidence, maybe you can be a little bit more accommodating. I think you're right that most oncologists do, especially when they get far out. But, a lot of times you should be a little bit more flexible even early thereafter because, you don't know. And I think, so there are many points. One, you can randomize people to testing strategies. Two, more information isn't always better. Three, we have very little data about the optimization of surveillance. I do think I say that somewhere in the book. And why don't we have more studies like this?
Yeah.
We're now 15 years later, and we have a paucity of studies. We have a lot of people who are making genomic tests. You can go listen to my videos on dynamic and listen to my videos on, I think before that, I think I did something, maybe that cancer type. For CUP, but we have very few well done randomized trials of testing strategies powered for all cause mortality, which is what this was. So,
okay.
Yeah.
next to your going next for the next point.
Yeah.
In the next point, you are talking about sample size, and you give many examples of when phase 2 randomized clinical trial did not translate to the same result in phase 3 trials. So maybe just take one example. I think it's a very striking example in soft tissue sarcoma.
Oh, the olaratumab
Yeah.
or Lartruvo.
Yeah.
Yeah, so, let's get into it. Okay, so accelerated approval has historically meant the approval of a drug product for a unmet medical need condition, okay, typically dire, rare, and few treatment options, on the basis of a surrogate endpoint thought reasonably likely to predict the hard endpoint, overall survival. So we can approve a drug based on response rate in some dire, rare malignancy. Later, we can do a post-marketing study and give it the full approval. That's what accelerated approval is in the law. When Scott Gottlieb was commissioner of the FDA, he wanted to make a little addendum, and he was influenced by Friends of Cancer Research, or as I call them, Friends of Pharma Research. They gave him a little white paper that said accelerated approval should be both a surrogate reasonably likely to predict benefit, but also overall survival measured with statistical imprecision. If there's a real big OS benefit in a phase 2 study, you didn't expect it, it wasn't the primary endpoint, but you saw it was a big OS benefit, we should give an accelerated approval rather than run the phase 3. And Scott Gottlieb said, yeah, I like that idea. But there's a big fallacy, okay? Because the uncertainty that comes from measuring a surrogate endpoint with statistical precision is a very different than the uncertainty that comes from measuring a hard endpoint with statistical imprecision. I'll talk about that at the end of this. So I think it's philosophically different, it's mathematically different, it's conceptually different, but he went ahead and said, you're uncertain that response rate means OS, and you're uncertain that this OS is real. It's the same uncertain, so let's approve it. And the drug he chose as the test case was olaratumab, which is a sarcoma drug, given in combination with doxorubicin for typically soft tissue sarcoma.
First line.
And what's the target? I actually forget the target. TGF-beta or something? I don't know. Some growth signaling molecule. It's an antibody against some... But I forget, actually. You forget too.
Yeah.
Okay, so that tells us something.
We try to really forget.
You tried to forget. Okay, tried to forget. Yeah, so I'm not sure. Listener, you check me on what the target is. But antibody. They ran a phase 2 study. The phase 2 study had accepted at a high alpha error. If I recall, it was like 10. It was 0.1. It's not 0.05. And if I recall, the primary endpoint of the phase 2 was PFS. PFS. And if I recall, it didn't have a significant.
It
had a PFS benefit. Yeah.
8 months benefit in overall survival.
In OS, okay, yeah, but I'm not sure. If I recall correctly, it looked like it was sort of trending to significance for PFS. It had a small benefit, but it had this. And I forget exactly if it was significant by the 0.1 alpha threshold, but not the 0.05. I think it's something in that ballpark. It was like kind of like, in other words, let me put it another way. It was like, weakly persuasive for PFS, which is the primary endpoint, not really even overwhelmingly persuasive for PFS. But for OS, something crazy happened. There was a huge OS benefit. Yeah. It was a massive OS benefit. I think it was almost like 8 months or a year. Yeah, it was huge. Yeah. And the p-value on that was very significant. That was a real, wow, something's going on here. But it was a small study and a small sample size. It wasn't powered or designed for OS. And it might be spurious. And so people may not know, but when you run an underpowered phase 2 study and you look at endpoints beyond the primary endpoint of the study, not only are you likely to get false negatives, like you're likely to dismiss a drug saying it didn't improve OS when in fact it might, but you're also, when you do get positives, they're much more likely to be false positives or have exaggerated treatment effect. And if you question that, go read the paper Power Failure by John Ioannidis and colleagues in, I think, Nature Biosciences, Biopsychological Science, something like that. What's my point here? Scott Gottlieb saw these results. He said the OS is really, really big. We should approve this product based on accelerated approval. And it did, lo and behold, came to market. And Eli Lilly started taking the money. 100 million, 200 million, 300 million, 400 million, 500 million. I think ultimately it made 600 million. Yeah. 5 to 600 million. Yeah. When the phase 3 trial comes out, boom. And it is the exact same trial as, the phase 2, but it had adequate power. And the curves are just plain superimposable. The addition of Lartruvo to doxorubicin didn't add a day of survival benefit. What's the take-home lesson? That 12 months was totally exaggerated. It was totally spurious. It wasn't the primary endpoint of the study. What other trial is like that? Oh, POLA-BR. POLA-BR is a lot like that. That's not the primary endpoint of the study. That's a spurious finding, if anything. And that's why you should be very cautious about underpowered phase 2 trials, non-primary endpoints, and large treatment effects. People love it. They say, oh, well, we had an OS benefit. You weren't looking for it. You weren't powered for it. And if you didn't find it, you wouldn't have even reported it. You would have dismissed it, right? It's selective reporting on top of it.
Maybe you can explain, because you're explaining this in the book, it's important because for people it's difficult to understand how this can happen. And you talk about regression to the mean. My understanding is that in early randomization, you can have imbalanced randomization, and this can explain these kind of effects. And the more you randomize patients, the more, when your sample size is adequately calculated, then this kind of effect are less likely.
Yeah.
The regression to the mean effect, you will tend to have a more precise estimation of the true effect in a sense.
Okay, yeah. So first, let me say the formal reason it happens. The formal reason it happens is the post-test probability that a finding is true is a product of the alpha, the power, and the effect size. I mean, that's a product of these three things. And there's an equation in that paper that when you play with that equation and you drop your power, you realize that your post-test credibility, your post-test probability it's true, plummets because power is an instrumental factor in the post-test credibility. So having 80% power is very different than 50% power. And that's why you might get this, and sort of the hand-wavy explanation, I think, is a little bit hand-wavy, is that one has to think about not just this trial, but the universe of all trials. I mean, in the universe of all trials, you're running them for response rate or PFS, all these underpowered phase 2 studies, and many of them find null OS, okay, because the OS is really null. Some of them find negative OS, but no manufacturer ever highlights that because that's against their product, and if it's really trending negative, they, kind of look the other way and they say, well, that's imbalance, that's random chance. And some find a positive OS, and that's what we're doing here. The other thing is we're looking often, we're stopping early, so we're picking it at the prime moment. And regression to the mean, it literally means that with more data, more events, more sample size, that it will regress to not the mean, but the true effect. And if the true effect is null, it will regress to the true effect. I do think, obviously it's just intuitive that if you randomize 2 people, chance events can play a role in the survival outcomes. 2 people is different than 2,000 people, different than 20,000 people. And so what's the role of these sort of chance events? And it just happened to be that Bob and Bill and Sue, who didn't do well, were on one arm. That plays much bigger role when the sample size is 20 than it does when it's 2,000. That plays some role, but it's also the whole ecosystem. I think we got to go back to that multiplicity point. Like, why is this happening? It's happening because we're churning all, and this goes to the point I'll make about Gottlieb. We have all these studies going, and you have to think about it. Like, if you're allowing the manufacturer to decide when to tell you the OS is promising, okay, back to my point. I said there was a difference between a statistically confident effect on a surrogate endpoint and a statistically imprecise effect on a hard endpoint like OS. I said that at the outset. And the difference is that a statistically persuasive effect on a surrogate endpoint, like response rate, let's say response rate, at the end of the day, one thing for sure, this drug does shrink tumors. We'll talk about, I-131, tositumumab, or Egfr soon, because I think that's in this chapter. But, one thing for sure, this drug shrinks tumors. And whether or not shrinking tumors make someone live longer, live better, we talked about that in chapters 2 and 3. But if you say we're going to take any OS benefit, even if you weren't looking for it, even if it's statistically imprecise, sorry, back to the point. You know for sure the drug shrinks tumors. So what's the manufacturer's incentive? To try to find drugs that shrinks tumors. When the more they try to find drugs that shrink tumors, they probably on average will be finding some drugs that actually help. Because they have to find drugs that shrink tumors. Okay, so now let's talk about the OS. Now Scott Gottlieb says, well, we'll also take imprecise OS. Well, that's uncertain. And now what is the manufacturer's incentive? Now their incentive is not to find drugs that shrink tumors, but to find trials where there is an OS imbalance. And what's the easiest way to do that? Well, one way is to make better drugs, but there's an easier way, and it's just to run a lot of trials. Just run a lot of underpowered trials, and then cherry pick the ones that are positive, because there's by fluke, by chance, some will have OS drifting one way or the other, and then submit those for accelerated approval. So Scott Gottlieb, by changing this rule, these are different types of uncertainty because the incentives to the uncertainty are very different. One is statistical precision in an uncertain endpoint, which leads the manufacturer to chase that endpoint, find drugs that shrink that tumor. But that's actually not a terrible incentive. It's bad, it's not perfect, but it's not the worst incentive. But the other incentive that Gottlieb is the incentive to find trials with imbalance in OS, which may not have been the primary endpoint. And that leads to the behavior of just running many, many small underpowered phase 2 studies, praying for a miracle. Okay, so I think he fundamentally changed it and that was what people don't see.
I think, unfortunately, because it was unfortunate, the result were not confirmed in the phase
Sure.
3 trial. But unfortunately, this trial and this sequence between the phase 2 and the phase 3, because I remember everybody was so enthusiastic about the phase 2 results.
Yeah.
I think it was a very important reminder of all these issues. So we picked this example, but it was a sad reminder, but an important reminder.
Yeah, a
The,
seminal reminder. Well, we ran out of space on one card. This video business is a very data-heavy business, so we ran out of space on a card. We looked up the mechanism of action of Lartruvo while we were gone, and it's an antibody directed against PDGFR alpha.
PDGFR. Subunit of
A subunit of PDGFR.
alpha. Yeah, absolutely.
Of alpha PDGFR. Yeah. Okay, well, I'm sure there's some listener out there who'll complain. But you know what it is? It's a drug that don't work, okay? Don't work. You don't need to know the mechanism of something that it don't work. It don't work. In fact, maybe it didn't hit no, I don't know. I don't want to get into that. But, you have to try to do some homework as to why it didn't work. Okay, so we're back. We picked up the phase 2, this whole thing about underpower. The last thing I'll say, it has a lot of relevance for the oligometastatic world. They've built a whole altar. They've worshipped their god, oligomet radiation, all on the basis of phase 2. So it would be nice for that religion to get a phase 3. We'll see. But so far, until they get a phase 3, I'm going to call it a religion. When they get a phase 3, I'll call it a science, and I'll start following it. All right.
Okay, let's talk about the next point. I think it's called response rates that go nowhere.
Oh, response rate to go. Okay.
So here again, you give a lot of examples. I encourage people to read the book again. But I think for me, and I was not aware about this example because I think when I started practice, it was already withdrawn. The example for iodine 131 tositumumab.
Yes. Iodine 131 tositumumab, or Bexar, the radionucleotide. And we take a big, potent I-131 and we tie it to an antibody that has an affinity for B cells. And this Bexar, and I think its other partner was a Zevalin, and they were FDA approved on the basis of a whopping response rate.
Yeah.
I love this example because the response rate is whopping. Everyone says, how are you going to argue with a drug with a 30% response rate? That's got to improve OS. And I was like, well, you know what? There was once upon a time a drug with a 60-some percent. What was it?
68.
68% response rate. And guess what happened to Bexar? It was voluntarily withdrawn by the manufacturer. And if you want to learn more about Bexar, read my paper in JAMA Internal Medicine, I-131 tositumumab, the story of Bexar. But basically, the long story short is it got approved based on response rate. They ran, I think one randomized study was the post-marketing study. That was negative. I think they then tried to use an ongoing cooperative group study to fulfill the post-marketing requirement. The FDA was reluctant because that cooperative group study didn't have standardized imaging, so it would have some things about it that were not up to the level of registration trials. But ultimately, that trial was also negative. And if I recall correctly, there was a third trial that was also negative. And if you pool all the trials together, it's either negative or like trending towards OS harm. And I think we did that in our paper. The bottom line is, here's a drug in the lymphoma space where you would think a very active drug would have clear and convincing benefit, but it has real toxicity. It's a radionucleotide. And in randomized data, over and over and over again, it didn't improve survival. And then ultimately, the manufacturer, with a gun to their head from the FDA, pulled the drug.
If I may, I think it's a very good example of the difference you make about activity and efficacy. And we talk a lot about that, and I think we'll be talking about that.
And just to hammer that point, activity means the drug shrinks tumor. What's activity? Response rate, CR rate, M protein falling. Efficacy means you live longer or live better. Overall survival, health-related quality of life. People think activity implies efficacy. It doesn't. If you want to know about that, go back to the video on chapters 2 and 3 where I talk about surrogate endpoints. Not everything active is effective. Meanwhile, if you're not active, well, you have a very low probability of being effective. That's something that I think I say somewhere in the book.
Later. I mean, your general point is you should have
activity.
It's
a screen
to pursue your drug, but it's not a guarantee for.
It's not a guarantee for patient benefit.
This is a good example.
And then the last point I make is that if you walk around an oncology conference, everyone thinks activity is benefit. They are totally misguided. They've forgotten where activity came from. They've forgotten what activity is. And it goes back to Mortel.
The next point is about some trials where we saw some advantage overall in the population, And later we found that it was actually just for some people based on tumor marker, on biomarker selection. You give the example of cetuximab. I think we could also give the example of EGFR or many others. But cetuximab, I think it's a very good example.
Yeah, so a monoclonal antibody against EGFR used in colorectal cancer in initial randomized control trial. I think people who had failed both 5-FU, irinotecan, maybe also oxali was sort of a last line trial, and it was showed survival benefit of cetuximab versus best supportive care in the initial study, and then cetuximab I versus irinotecan, cetuximab has a very modest survival benefit in colorectal cancer. It got an approval for sort of all colorectal cancer. Then as time went on, I believe it was the Canadian group in 2008 or 9 that identified that there may be at least two populations. Let's say that at least two populations. There are people who get cetuximab who have activating mutations in KRAS and RAS, and those people appear to derive no benefit, maybe even a harm from the drug. And there are people who have wild-type RAS, and they appear to be deriving the benefit, and their benefit is actually greater than the average benefit. So the average benefit we see in colon cancer is a mix of two things. People with RAS who are getting no benefit or even harmed, and people with wild-type RAS who are deriving a bigger benefit. And as time has gone on, we keep moving that bar. We find extended spectrum RAS testing, and BRAF has implications, and we keep moving that bar and teasing out who's benefiting from cetuximab. That group's getting a bigger and bigger benefit, and who's not benefiting. And we're pulling them out of the cetuximab treatment. And I think it's really important, which we were about to say, because it has implications for everything in medicine, this kind of example.
Yeah. So an important trial and in the same, I think. And also maybe in more recent trial, sometimes we lack this kind of biomarker selection.
Yeah.
And it's not really in this chapter, but it's also an important point to make.
Yeah, so I want to make that point, let's take a trial like Keynote 177. Okay, MSI high colon cancer in the front line. But the curves cross. Because there's a fraction of people who get a benefit from Pembro, but there's a fraction of people that only get the benefit from chemotherapy, and they're not getting the benefit from Pembro. And the purpose of, I just want to step back and say, when we make inferences about individual patients in cancer medicine, we use group data. The holy grail in all of science is to know the counterfactual. Like, if you have me, like me and flesh and blood, Vinay Prasad in your office, and we did this, what would happen to me? What would happen to me if we did this other thing? What would happen to me in this other world? But we never know what would happen to you in the multiverse you live in, unless you watch a Doctor Strange movie. You just don't know what would happen to Vinay Prasad or Timothée Olivier. You never know. So how do we make an inference about us? Well, we look at a group of people. And a group of people like you guys, your age, your build, your height, your weight, your medical problems, like you, who happen to have this condition, if we randomize those people to this or this, what happens to them on average? Okay? But anytime you do that, that effect only applies to the practice on average. And so I know that when I read a clinical trial and there's a convincing OS benefit, I know if I do this trial with everybody like this, I will on average benefit my patients. But I never know for the individual if they themselves benefit. And the purpose of this stuff, where we find RAS, et cetera, is to show you that don't be surprised as time goes on, some smart person realizes, well, there's two groups in there. And it's actually even more complicated than that. There's each individual is getting an individual treatment effect in a counterfactual world. We can't estimate that. The best we can do is just keep carving this up into groups, smaller groups, pulling out the people who really benefit from the people who don't benefit or may be harmed. But, all of our therapies have huge groups of people who don't benefit and may be harmed. Very likely. And we should be investing a lot of resources in trying to figure this out. And, of course, the manufacturers of Pembro and Nivo, they don't want to. They have their nested subgroups rather than adjacent subgroups we've talked about in some publications. They do everything they can because they want the largest market share. They want big market share. They want to give you the drug early, often, for the rest of your life on maintenance, and they want no biomarker selections to get the whole market share. But of course, what the patient wants is more and more biomarkers to pull out people who are really not benefiting from those who might, for those in whom it might be worth the toxicity and time.
Okay. The last example is about non-inferiority trials. I think you will be happy to talk about the REFLECT trial, non-inferiority trial of lenvatinib against sorafenib. And it's also an example of many issues related to non-inferiority trials in general.
Okay, let's do it. So I guess I would also say that there's some really nice papers you could read. Alison Haslam and I have a paper in JNCCN. I wrote an editorial for a Scott Abereg paper in JGIM. That's a really important paper. But what's non-inferiority? You know, there are really two fundamental types of statistical design. Superiority, you're going to show me you're better than something else in terms of some endpoint. Or non-inferiority, you're going to show me you're not worse than something else. You're no worse than something else. You're not worse. You're not inferior. But it's not worse than some margin or some delta. You know, yes, I could be a little bit worse than that, but I'm no worse than whatever this acceptable margin or delta is. Okay, so that's a non-inferiority trial. I'm not worse than, you know, upper bound hazard ratio 1.08. I think that's what it was in this study. I'm not worse than, you know, 80% of the treatment effect of the drug. I'm not worse than, you know, the drug has a 3-month survival benefit. I'm at least a 2-month survival benefit. But there's some margin or delta that you're going to show that your drug is at least that good as the parent drug or the parent intervention, and no worse than that margin delta. But what are the things you need to know? Number one, you should never run a non-inferiority study unless you have a pre-specified rationale. What's the rationale? Your new drug got to be cheaper, it's got to be more convenient, or it's got to be less toxic. And if it's not cheaper, if it's not more convenient, if it's not less toxic, do not pass go. You should not run a non-inferiority study. Because why on earth would someone want to take a drug that might be worse than the other drug, but it's actually the same price or more expensive? It's equally a pain in the ass to take. And I made a mistake. I was supposed to not swear.
Yeah.
Or the toxicity, it's equally or more toxic. So let's talk about. So we went from I think that was PG-13. That wasn't rated R.
PG-13.
By saying.
Okay. No, I think it was better than
before. It could be worse.
Yeah.
It could be worse.
It will be better.
I'm within the margin, the non-inferiority margin of what was pre-specified. I see. Okay.
Maybe 0.6.
0.6. Yeah. So what's the point here? Okay, now we talk about Lenva, sorafenib. Sorafenib is the standard of care based on the SHARP study in advanced or metastatic HCC. Those patients were mostly good Child-Pugh status. Lenva comes around. Here comes Lenva. Lenva wants to run a non-inferiority study. I think the upper bound hazard ratio was 1.08, meaning that they had at least 60% of the therapeutic efficacy of sorafenib, which, if you ask me, is not that great because sorafenib wasn't that great to begin with, but they're running their study. But let's ask the questions. One, is Lenva cheaper than sorafenib?
No.
Is Lenva more convenient than sorafenib?
I can't make the same thing, but no.
Is Lenva less toxic than sorafenib? So should they even run a non-inferiority study? No, they shouldn't. You should not be allowed to run a non-inferiority study. This is violating the basic principles of non-inferiority. So that's the first mistake. The second mistake that we need to talk about, the margin. They're picking these margins. Do I want a drug in metastatic unresectable HCC that's only 60% good as sorafenib? No, I want a drug that's better than sorafenib. What, sorafenib wasn't that good? What are you talking about? At 60% is good. Get out of here. That's not good enough. And we know, in the paper that Alison and I did, that if you look across non-inferiority studies, they often favor the manufacturer because they pick a margin super big. And the analogy I always tell people is it's like a driving test. You know, you go on that driving test, you got to drive, make a left turn, put the signal, and do all this. I think the last time I did it, I was 15 years old or something. Been a long time. But the last thing you got to do is parallel park a car. And, you know, I think I did it in, oh my God, my parents used to have like a 1985 Dodge Caravan. No, maybe 88 Dodge Caravan. I had to parallel park that. It wasn't easy to parallel park. And they pull up to a spot, they say parallel park that thing. I say, oh my God, I parallel. But I did it and I passed the test. But parallel parking is the analogy because it's difficult to parallel park your car in a space that's the exact size of your car. But after years of living in Chicago, I became able to do it. I can parallel park a car with 1 inch on either side because that's what it takes to live in Chicago, my friend, and not pay parking. If you live in Hyde Park neighborhood, circa 2005, that's what you got to do. Okay, but it's a lot easier to parallel park a car if the space is as big as a school bus. You don't need any skill or talent. And that's what a non-inferiority study is. If the margin is so big, you can parallel park a school bus in it, well, then it's really not telling me that much. We have non-inferiority studies when it comes to the DOACs and Coumadin, et cetera, et cetera. But I think those were the sort of the main principles. There's a lot more in the book, I think.
Yeah, I think one important finding was in only 30% of trials they were justifying the choice of the margin.
Okay, yeah.
This was the work, I think, with Alison.
With Alison, yeah.
There's another work where they find that out of 57 trials, 55 trials were positive. I mean, 96% of trials were
industry-sponsored. Yes.
industry-sponsored non-inferiority were positive. So this doesn't tell. This really tells you about. I mean, are you just guaranteeing your results by the design with large margins?
And I think like one of the authors of that study said something like, if you're running trials where 97% of the time you get what you want, if you're really running trials like that, then you know what? Let's just all say you don't have to spend the money and you don't have to squander the patient's time. I will just concede to you that you're not inferior. I mean, if you're running trials consistently with a 97% success rate, don't even wait. Let's not randomize patients. There's real human beings, you know? Let's not waste their time, make them do blood draws, all this bullshit, all this unnecessary things. All these unnecessary things. Let's just concede that you're not inferior because 97% of the time you're going to be there anyway. And so I think it's a really telling point that trials have to also sometimes be negative for them to be worth running. If they're always positive, you don't need to be running them. And in this case, it's not always positive because all these drugs are so wonderful. The more plausible mechanism, and the reason that is the case, because then when you run superiority trials, they're not 100% positive. The more plausible mechanism is you're gaming it, man. You're gaming the non-inferiority study. You got a margin so big you can park a school bus in it. You're doing it where it don't make sense. And why are you doing that? Because you want to make your company rich. I get it, but the FDA should say no. They should say no, but they don't.
So now we will go to a positive note, but it's not finished.
Okay.
Which example of very good trials? And I give you a hint.
Oh boy.
No, I give you a hint.
Oh god, I'm going to look at it.
There were CHOP, and the biggest advance since CHOP was invented was the addition of
rituximab.
Yeah.
Oh, okay. Yeah, I'm pretty sure that's one of the things I was thinking about. I think it's in my thread too of the trials I really love. There are at least 2 studies to my knowledge, and maybe even more, randomized controlled trials with overall survival as the primary endpoint showing the addition of rituximab to CHOP in non-Hodgkin's lymphoma or DLBCL has a survival advantage. And the first one was in people over the age of 65.
Yeah.
So wow, they took the older patients who are always neglected from trials. They gave them CHOP or CHOP plus Rituxan, and they showed that curative fraction is higher with the addition of rituximab. And then they did it in everybody. And rituximab has been a revolutionary drug. And so what are the strengths of that? Well, you have a really good drug. You targeted a population that was vulnerable that needed something. You went for overall survival. You achieved it. I mean, what's not to like? I think that's great. I mean, and I think that's a drug where there's no dispute. I mean, I don't think anyone ever said CHOP is better than what am I getting from adding the R to CHOP? We know from CHOP and promicidabine and all that stuff that maybe there's a ceiling effect. We were talking about this the other day.
Yeah.
There may be a ceiling effect to what you get from chemotherapy or cytotoxic, but Rituxan unlocked something that you weren't able to get. Yeah. And then it also the listener will know, Rituxan also changed the game on CNS relapse. All the CNS relapse rates started to plummet. And so a lot of our thinking on CNS relapse, which by the way is based on nothing, really no good randomized studies, it should be revisited in the era of Rituxan, and it really should be revisited in the modern era. And good people like Toby Ayers and Graham Collins, et cetera, are trying to. But really, gosh, would it kill us to do a single randomized trial on CNS prophylaxis so we might have an ounce of data in this sea of opinion and nonsense?
Okay, so you give many other examples in this chapter, so I really convey the listeners to
just
to
one
check
example
out.
From each section, because there's a lot.
Yeah, and so
There's
I tried just to pick one in each subsection. Do you have final thoughts about this chapter of important trial before we go to global oncology? I think your main point is that there are some trials you should know, even if they are old, even if they are not relevant to your practice, like the example of Lartruvo, because it really helps you to appraise the modern trials. And I think it's really the point of this chapter, right?
Yeah, I mean, what is the point of this chapter? I mean, I guess I'd say, if we go back to the beginning, the introduction sets out this idea of the story of autologous stem cell transplant where people were seduced by response rate, a measure of drug activity. The money comes in and, they start doing it. And then it turns out they do 6 randomized controlled trials and they don't improve outcomes and there's a lot of toxicity. And you're like, you finish that and you're like, oh my God, their whole book's written about that. What a terrible chapter in oncology. Surely they learned those lessons. They internalize those lessons. They'll never make those mistakes again. And then the book starts opening, Let's talk about the drugs, what they've, the first section, cancer drugs, the outcomes they improve and at what price. And we talk about, how well they work and what's the evidence and and how much they cost and what's the dollar per quality. Then we talk about surrogate endpoints and the story of Mortel and the dining table, and we've talked about it. And then we talk about what does high drug prices really mean to a society, and that should all give you pause, like, maybe this problem is deeper than just the introduction. Then the second part, the societal forces that distort cancer medicine, the part that I think is the most important, that some astute reader said it should have been cut, but no, it shouldn't have been cut. No. It's the root of it. And the root of it is like why human beings are optimistic and their spin and there's financial conflicts and all this stuff. And precision oncology is like, at least for a few years, is like the culmination of all our biases and all the money and all that stuff coming together. And then the third part, which we have been slogging through on this podcast over and over again, because to some degree, it's the hardest to explain. It's the most technical part. How to interpret cancer evidence and trials. And I start about study design 201, teaching about observational studies and all these things. Principles of oncology practice, these tried and true, not ancient, but relatively, powerful and persuasive and agreed upon principles that we were doing until very recently. And then important trials in oncology just give us some history, some lesson. And I would say, and this is, not to sound arrogant or anything, but I would say that like the one thing that if I was if you're like a fellow in Hem/Onc, the one thing that you should read is section 3. I mean, I think you should read the whole book because by the end I'll try to tie it all together. But you really need to know section 3, and it's the thing that I think like you could go a long time in oncology without learning all these things. Sometimes you barely get a glance of it in fellowship, and then you learn it on your way as an attending. Sometimes you don't even learn it there. But what's the goal of this section? This is what, most of the research we're doing is in this space. This is what our laboratory focuses on, trying to understand how do you make sense of evidence for people in front of you. And I think you need to know a lot of these things.
Great.
On that positive note.
Great.
So, all right, so let's close this video. We'll pick up the next video. This is episode 7.
Yeah, episode 7.
Malignant Book Club. Timothy Olivier from Geneva Hospitals. Practicing
Vinay Prasad.
Vinay Prasad from